I'd like to welcome you all to our weekly call on MS and COVID-19. For those of you joining us for the first time, we started this call several weeks ago as a platform to share data on how COVID-19 would affect our patients and our practice. Just a few housekeeping notes before we get started. Please remember that the call will be recorded and posted on the iWiMS website in a couple of days' time, more or less. You can take a look at all the calls there as well. If you share the information presented here in your scientific circle or social media, please acknowledge the presenters and iWiMS. All persons not presented will be muted. Presenters will be unmuted or can unmute themselves when it's their turn to speak. Also to the speakers, please remember to unshare your screen at the end of your talk. In this call in particular, we will take questions after the invited presentation and then after all updates on MS COVID registers have been presented. So all speakers are given enough time to share their slides. Questions can be posted at any time using the chat function. You will see the button with the word chat at the bottom of your screen. So, without further ado, I'm happy to introduce our first speaker, Professor Heinz Wiendl. Professor Wiendl is the head of the neurology department at Münster University in Germany, and as his research focuses, among other topics, on immune regulation, MS, and its therapies, we invited him to talk about the role of B-cell depleting therapies on COVID-19 patients. So, Heinz, thank you for accepting the invitation, and you can start whenever you're ready.
Yeah, Georgina, thanks very much for the kind introduction, and thanks very much for the invitation to this extremely interesting format and very high-level faculty, I have to say. So very honored to speak here. I'm trying to share my screen now, and I hope this works. So I was asked to talk a little bit about MS, COVID, and the specific aspect on B-cell depleting therapies. And I'm not sure what you have already discussed over the last couple of calls, and I'm trying to share probably not too much of my wisdom, but maybe some thoughts around this topic, because it's more around what do we do in neuroimmunology when we don't know how we do it. So this is, to start, this is an image that can you actually hear me quite okay from the
Yes, we can
sound? So this is a picture that my daughter, she's 16 years old, drew a couple of weeks ago when we were in full lockdown. This is actually how young people feel in the COVID pandemic. Locked down, isolated, but swamped with all this media. And this is actually also what happens in a way with our neuroimmunology community. There is a lot of new sorts and types of information apart from the classical publication formats, Twitter, social media. Everything's extremely dynamic, and what you heard yesterday might be really changing already the day after. What are we talking about? We're talking about a viral disease that obviously poses two sorts of problems. One is, are people that are under specific disease modification at a higher risk for acquiring this infection? As we know, MS patients might, under certain therapies, be immunosuppressed and thus be susceptible to certain types of infections or pathogens. And the second is the specific nature of COVID-19, which is shown here, that obviously the more severe courses and the problem comes in the secondary phases of the disease. You could call it oversimplified a secondary hyperinflammatory response, which sheds a different light on patients under immune therapy, saying that dampening the immune response might even be protective in those that acquire the immune virus. And what do we know as of today? I mean, I think risk factors for more severe COVID disease are listed here. This is probably one of the most prominent papers from China that brings male, that brings age, that brings comorbidities. But what hasn't been really listed here is immune therapy. Certainly not autoimmune diseases per se, and not specific therapies, as is the topic of today, B-cell therapy. Well, question one is, are MS patients in general at higher risk for infections? This is what we are concerned of. This is what many MS patients under immune therapy are concerned of. In general, I would say probably not too much. If you look at this most recent publication from the Swedish registry, you would acknowledge it, at least, however, with all the therapies, even the so-called platform therapies, interferons, you have a slightly elevated risk over the years on a population level for infection. So this is already, let's say, what makes the statement correct, that people under immune therapy are at higher risk for infection. This is why several authorities have recommended more stringent confinement. If you look here for Rituxan, this is B-cell depletion, looks particularly different from the general population, makes an argument to say, well, those patients might have indeed a higher risk. What do we know about COVID and immune therapy so far? This is a very recent publication. I think most of you have noted in the New England. It's a letter that investigated patients with mainly rheumatic disorders and different sorts of therapies, not including really MS therapies. And the conclusion here in this paper is that the disease courses didn't really differ very much from the general and comparator population. I mean, it's a very short and brief publication, a letter that is already indicating that it might not be a complete disaster to be under immune therapy, even under heavier immune therapy. This is all diseases not really including multiple sclerosis. Even higher immunosuppression, liver transplant patients seemingly are not brutally different, at least with small case series. This is an Italian case series. Patients following liver transplantation, also showing quite, let's say, modest numbers as compared to the general population in terms of severe courses. We just have submitted a paper that tried to collect what is really currently out there in terms of recommendations and immune therapies. And what we did is something like a pseudo-Delphi approach, because what happened is that all different authorities and societies give statements and recommendations based on best educated guesses. And what we did is we therefrom kind of collated questions and then calculated what is the consensus within the questions, and the real approach in a way that all societies have taken, of course, their responsibility to say something and state something, but there is so little knowledge apart from, let's say, analogy conclusions from what we know how MS patients behave in general and what's known about safety profiles from different disease-modifying treatments. It's interesting to look here. That is question 10. Are patients with B-cell depleting therapies at risk for infection or a severe disease course? This is already a key question for today's conference. And there is a pretty high consensus to say, well, B-cell depleting agents increase risk of infection and a more severe course of disease. in COVID-19. That continues with question 17. Should one delay the next cycle of an interval therapy? This is interval therapies, including also now alemtuzumab and cladribine. Also quite high consensus in saying, yeah, interval therapy should be delayed. Just bringing up the problem with the term delaying, looking at the time course of the pandemic, we might not be super successful in delaying for 6 to 8 weeks or whatever. These are the extreme positions that I would like to go through arguments. So one extreme position is B-cell depletion reduces humoral immunity, is partially immune suppressive, and therefore puts MS patients at a risk for more severe COVID-19, which means don't continue the therapy, don't initiate, delay further infusions. The other position could be B-cell depletion has only very modest effects in general on immunocompetence. What we know in terms of higher respiratory infection rates is mostly bacterial, not really viral. And here even an argument to say, well, reduction of antibody production might even be beneficial for secondary hyperinflammation. So there is not a major concern to continue or even to initiate or optimize if needed. And here is a couple of arguments that could be brought forward. So first of all, how are primary immune reaction altered under B-cell depletion? There is quite some knowledge on this topic, both preclinical, less so clinical. What you could say quite safely is that obviously CD8s and innate responses are not really obviously impaired, and this seems to be especially in the primary phases of immune reactions most important. The other is, what do we know about responses, immune responses following vaccinations? Here we deduce most of our knowledge from the Veloce study, which is currently in press. What I found here is this poster. It's very small, of course. On the other hand, what is relevant for the discussion today is here. So what has been done here is to test against different antigens, but most of them are really antigens that challenge secondary immune responses, like tetanus or pneumococcal vaccines. And only one antigen, KLH, has really tested humoral immune responses to neoantigens. KLH is probably not a superb paradigm, but what you can say from this study is that patients under B-cell depleting therapy, and this is here ocrelizumab, are able to mount humoral immune responses to vaccines, but also neoantigens, but not to the same extent. They're looking quite reassuring, honestly, for things like tetanus, but they don't look particularly well for things like like KLH, which is a big protein. What else do we know? I mean, there is one publication on Rituxan with a quite similar mode of action. Others would say identical, using bacteriophages, which is also promoting cellular immune response. So that is what we are concerned momentarily. So what about the capacities of priming primarily immune responses? And here the paper shows there is definitely a attenuation or a diminution of primary and secondary antibody responses. There is a single case report that's quite interesting from Antonio Celli's group that has observed a patient that was antibody negative for varicella zoster and experienced the primary infection of this herpes virus after ocrelizumab initiation, after 3 months of initiation, and did extremely well in terms of mounting cellular plus humoral immune responses. So that could be taken as a quite reassuring message that it is possible to react to certain types of viral infections quite appropriately. So what could be the conclusions? And I think this is an important slide to go through. So first of all, I think what we know from the Veloci study, it's relatively reassuring data on vaccine responses for secondary immunization protocols like tetanus, influenza, pneumococcus. It's less reassuring for primary vaccination responses, rather little data on KLH and bacteriophages. That could indicate that one problem is that class shifting is not successful. So to mount really a protective immune response, you need a class shift from IgG-M to IgG. So that might be a problem in being B-cell depleted. And that could be a problem if in the end, whoever develops a successful treatment or a antiviral vaccine, that we could end up in cohorts of patients that make rather poor responses with neutralizing IgG or mucosal IgG and IgA antibodies. I think that is just a theoretical concern, but based on what we know, we can't really exclude it. What we know for the moment, and I'm continuing with some more data on this, is that obviously patients seem to handle the infections rather well. But I personally think, and probably some of you might agree, it's really a matter of timing, and it's a matter of how deep the depletion is within the compartments, because I think some pre and B cells in the body are still existing and probably are needed and still sufficient maybe to help in mounting a sufficient immune response. I had some communications with Roche people, not on the occasion of this talk, but at several occasions, and what they are planning exactly for the arguments that were just raised. They're planning a large vaccination study, especially to answer the question on primary immune responses, not using then KLH, things like rabies would be more appropriate. And what I just said is the timing of the vaccination in trajectory to residual or repopulation B cells is key. Another argument is the role of IL-6. More severe causes of COVID are very depending on IL-6, and this is an argument why IL-6 modification is used as a therapeutic strategy to dampen this hyperinflammation. What has been done with the OPERA and ORATORIO trials is to measure IL-6 levels under depletion, and they stay continuously. So that means B cells are obviously not key players in modulating or in itself producing IL-6. So that might be a small argument in the line of arguments. How relevant is what we know of B-cell therapy, the lowered immunoglobulin levels for COVID-19? So what we clearly know is that you have a reduced primary humoral immune response, and that could be a problem against SARS-CoV. It could be beneficial as, for example, antibody-dependent secondary cytotoxicity mechanisms might not be so overwhelming. And one very, I find, interesting argument in this direction is a paper that is shown here from a Wuhan group that assessed more than 200 patients with a index that measures lymphocytes versus neutrophils versus immunoglobulins, and end up in saying that higher IgG levels are associated with a more severe COVID disease, and arguing that that might be because higher IgGs promote maybe even higher levels of the secondary cytotoxic mechanism. So that's all very theoretical and not really directly related to B-cell depletion, but I'm just, listing arguments. what can we know from infection patterns under B-cell depletion? I already made some comments. So statistically, on a cohort level, the IgG decline that we see in B-cell depleted patients is not statistically really associated with a higher infection risk. So that's robust safety data. Could be still a problem on an individual level. What you will know is that the respiratory infections are higher in B-cell depleting therapies, but those are mostly bacterial. Much more than 70% are bacterial infections, not that much viral infections. And there is only, well, no, I shouldn't say only, but there is one virus group that is of particular concern in the context of B-cell depletion, that is hepatitis virus B and C. So this is what we know and what we are concerned about. So now, what do we know about MS patients and B-cell depletion? That is data that change every day. We had, when all the mess started, some correspondences and conferences with Wuhan hospitals, and they were extremely concerned about patients under B-cell depleting therapies because they claimed that humoral immunity would be most important. That is nowhere really published. It's a telephone conference, and that scared us a bit. On the other hand, we have now, and I think this is also part of this call and has been discussed, now first data from registry experiences. One came out a couple of days ago from the Italian group led by Maria Pia, the Italian experience. I got data via Roche. They have a number of 100 patients that were reported to them experiencing COVID infections. I'm showing you the outcomes just in a second. And there is 2 case reports of COVID-19 under B-cell depletion, which so far show no sign for a disastrous disease course, even the opposite, more protective in some cases. So this is Maria Pia and the Italian registry, which in the end, with a rather low number, comes to the conclusion that immune therapy in general, but maybe specifically also B-cell depletion, is not based on very low numbers, not associated to dramatically different disease courses. And this is interesting because it's nowhere yet published, but it's a manuscript submitted. This is 100 cases that the Roche database has, and 74 of those were confirmed, 26 unconfirmed, whatever that means. Confirmation means either clinical confirmation or testing. And what you can see is from those 100, most of them were not hospitalized. From the hospitalized ones, 5 ended up to be critical, and 8 ended up severe but not critical. And this is the status that 2 from the very critical are recovering. 1 is still on ICU, 1 is ventilation, and 1 is with supported ventilation. So again, here, no real robust calculation possible, but no sign of a clear, dramatic, fatal promoting outcome under ocrelizumab. And this is actually the summary. Maybe you could call it a personal statement, but this is at least to what we come as a conclusion with this, pseudo-Delphi approach, enriched with some additional thoughts. This is summarizing what international and national recommendations state in terms of what we know about risk of infections with B-cell therapies and the levels of immunoglobulins and how that relates to infection rates. What you should know, and I think that's clear, that B-cell depletion has a pretty long-lasting effect. If you look on ocrelizumab, it takes indeed up to 72 weeks until you really recover completely with all your immune cell population. There is, I mean, and that depends on more factors than just the theoretical pathomechanistic considerations. That considers also access to infusion centers, whether hospitals are cold zones versus hot zones. So you could consider, and that was a discussion several weeks ago, to delay in some risk groups a next infusion. But we feel at the moment that there is no principal objection. I think that is an important statement. No principal objections also to initiate patients under given risk-benefit considerations in the situation in suitable patients. I mean, you cannot bridge forever. You cannot undertreat patients forever. But what we feel is a group we would probably not go for B-cell depleting therapies now currently is particularly older patients and patients with comorbidities, because I mean here factors such as immunosenescence and risk factors for more severe COVID come into play. So older patients with progressive disease, and I think this is for the question for continuation, they should be viewed with caution. That is at least a view that could be shared by, I think, many MS treating physicians and authorities, because they might be really less suitable. And last but not least, this is some of a conclusion figure. So what is really changed in our neuroimmunology thinking in the light of COVID? I think we are discussing three dimensions, which is in a way the essence of neuroimmunological treatments, and all dimensions have its justification. If you look at dimension one, I mean, first of all, it's the disease itself, but it's patient-related factors, it's physician-related factors, and in the end, and that is a clear fact, you have environmental factors that play in decision-making, and you have then the treatment-related factors. In the end, the risk profile, the mode of action, the safety profile of the individual therapies that make a risk estimation. Dimension two is where you are. Is it initiation? Is it continuation? Is it optimization? And dimension three is the angle, how you look at it. So are you considering the problem more on the side of, I don't want to have any increased risk that my MS patient acquires COVID-19? Or is it, if the patient acquires it, what does this immune therapy do in terms to prevent a more severe COVID-19 disease course? So I think this is what COVID-19 brings as a flavor into otherwise very established, albeit complex algorithms in decision-making in neuroimmunology. And this is, I think, all I had put together for today. Thanks for listening.
Well, thank you very much, Heinz, for this very comprehensive talk. I think that, well, there are several questions there already, but I think we better move on to the other speakers and leave all the questions for the end. So the next speaker now will be Anneke Van der Walt. She's a neurologist and a neuro-ophthalmologist, I believe, at the Central Clinical School and Monash University in Melbourne, Australia. And she's going to present data on the Australia-New Zealand COVID-19 set and also the MSBase COVID-19 data collection module.
So, Heinz, you may want to unmute, log out of the shared screen, if you don't mind. Thank you.
There. So, Anneke, are you ready?
I am. I'm just sharing my screen.
Now, perfect.
Right. So thank you for inviting me to speak. I am planning to give you an overview of, this shouldn't take very long, there's some cases and data collection efforts in Australia and New Zealand. And then I'm also really pleased to provide the group today with some information on the data collection efforts that's being rolled out in the MSBase registry. So we've been quite fortunate in Australia and I'm also talking about New Zealand, I guess, because some of the data here is collected from New Zealand as well. And we can, in Australia, we've not had that many cases. So we're sitting as of just a few hours ago at just under 7,000 cases in total, with 97 deaths recorded, with almost 700,000 patients tested. So the testing effort has been very strong and very coordinated. So we can see that in terms of the curve, we certainly have smashed it. And looking at New Zealand, a similar type of situation where there's only just been about 1,500 cases with 21 deaths recorded, and you can certainly see that over the last 24 hours, not very much has happened. So in Australia and New Zealand, we have the Neurology Association. It's called ANZAN, and it represents neurologists in both Australia and New Zealand. And within this organization, there is a multiple sclerosis interest group, which is a combined group of any neurologists in the two countries who have an interest or who look after cohorts of patients with MS. So it's quite a wide group in that it includes neurologists, of course, attached to large academic centers, but also anyone in private practice or people who are more generalists as well. So there was, from the beginning, a coordinated effort by the group to develop a consensus guideline, which would provide advice for neurologists around how to manage disease-modifying treatment, and also advice for patients, which has been to be consistent with advice given to patients. And it's quite, given that it's quite a close-knit society, we've been, quite lucky in that way, in that the care would be quite consistent across Australia and New Zealand. Now, this effort is also supported from an administrative point of view by MS Research Australia, which has been quite helpful because it's allowed a platform to actually provide the advice to patients that they can actually download and see in a centralized way. So our data collection, initially we set it up as a Google Sheet, with this being with a Google Sheet behind the Monash University server, and we aligned the data fields with the MSIF and MS Data Alliance data collection fields, so that we can share that with the international and the global initiative to collect data on cases. So the advantages to have it initially set up as a Google Sheet is that most people could access this quite easily after given permission to access the sheet, including practice and rurally. And we, over time, also expanded access to include any nurses working with people with MS. So this would be anyone registered with MS Nursing Australia and also MS Nursing in New Zealand. So these are two separate organizations. We were able to make sure that anyone who requested access was actually registered either with ANZAN or with the nursing associations. So a summary of cases this far. So the prevalence has been, it's been really low, to be honest. So we've recorded 4 cases of COVID-19 infection in Australia and 1 in New Zealand. And all of these people were symptomatic and met the WHO case definition criteria. They were all confirmed by PCR. 3 of these cases were returned travelers, and 1 was a community-acquired infection. If I just summarize the demographics and the disease-modifying treatment exposure in these few patients, the average age was 36. They were all relapsing, remitting, and we only have 2 EDSSs available, and 1 of 1.5, 1 5.5. 3 patients were on fingolimod and 2 on ocrelizumab. In the fingolimod group, the lymphocytes counts were 0.4, 0.4, and 0.6, so which was pretty standard for people on that drug. And ocrelizumab, the patients last had received infusions in December and then in January. So we didn't, unfortunately, we only had a B-cell information on 1 patient, and they were completely B-cell deplete at the time of acquiring the infection. In terms of outcomes, most of these patients were at home and had fully recovered. There was 1 patient who was a fingolimod patient at the age of 59 who was admitted to hospital for 48 hours just for observation, and was then discharged and has fully recovered as well. So I think this is in many ways consistent with some of the cases reported by other countries. At this point, we can't really make any hard and fast conclusion, of course, as to what would happen to other people with MS who might acquire this infection. So I might move straight on. I also work quite closely with the MSBase Foundation and the MSBase Registry. And I wanted to share with you the MSBase plans to roll out a COVID-19 data collection module. So as everybody, most people would know, the MSBase is an international MS registry focused on outcomes. And as of yesterday, there's more than 70,000 patient records with 145 clinics participating in 36 countries. MSBase runs its data entry mostly on a software platform called iMed, but the MDS software, which is a specific software owned by MSBase, has also been rolled out in many centers and hopefully will be acquired by more and more centers going forward. So this is the systems that are generally used for data entry and are both managed centrally. So within these systems, we have developed, and these are just the mock-ups I'm showing you, so it's very, very early information. But basically a mock-up, this is the mock-up of what the data entry module will look like, and hopefully this will be ready in a couple of weeks. Where in the MDS, which is the more recent version of MSBase data entry software, we are able to use MEDRA codes. So the MEDRA codes will be included in this, and it will be logged under the medical condition tab and also under the safety tab in the registry. So this would basically capture very simple information. I think our focus is very much on ensuring, that we get the most crucial information with the minimum data for this really being the date of the onset, the diagnosis being confirmed or not, and also the outcome of the infection. As the MSBase data set in general would also already include an enormous amount of information on disease-modifying treatment and past medical conditions and demographics. So this would already be up to date, so no need to, hopefully update that for patients, but people will be prompted to do that, of course. So the diagnostic tests will be confirmed as well in terms of PCR serology and also chest imaging findings. So I think many other registries I know the North American one, for instance, have much more detail about what those chest imaging findings look like, but we kept this quite simple. A recording on symptoms, which is of course quite important if you have people with unconfirmed diagnoses, other medical conditions. So we're looking at pregnancy, smoking, obesity, and then the other comorbidities, and was prompting to also complete these on the other information sheets that is in the data entry software and required. Histology tests can be filled in on this data module, but also in other parts of the registry, of course, and people will be prompted to do that. And then the outcomes is kept quite simple with hospital admission, ICU admission dates, and recovery or death recorded. So we're hopeful that this will be available and rolled out as an update to software and iMed and MDS very soon. In the interim though, because we know that many of our members are in countries where there has been a huge number of cases already and are quite desperately looking for ways to record these, we will roll out just a paper-based version so people could keep track of patients, which will also be very soon available on our website. The plan is, of course, that we are collaborating with the global initiative by the MSIF and MS Data Alliance, but also with the big MS registries, which hopefully will provide more of a longitudinal perspective on outcomes and risk factors with more in-depth information available in the big registries, of course. So that's really all I had to say. So yeah, I'll leave it there.
Thank you very much, Anneke. And it's also good news to know that the disease has been more or less contained so far over there in Australia, New Zealand. And well, let's hope the MSBase helps us, or all the centers are based in. So we are now going to move to the next talk, which will be presented by Maria Pia Sormani. You all know her. She's a professor of biostatistics at the University of Genoa in Italy, and I think she's going to share data from the Italian study group on COVID-19 infection in MS, which was just recently published, as it was mentioned earlier by Heinz.
Here we go. Hello, everybody. Let me see if I'm able to, okay, put this as a presentation. So I'm going to present you some results from the Italian initiative that is a registry dedicated to collection of data of COVID. Here is the website and the link to the platform. It is available to everybody who want to join the initiative, and I have some data of the enrollment up to now. We have now around 600 patients with MS included in the platform. Most of them are from Italy. As you can see, we have 37 international centers who activate their participation on the platform, but just a few of them started including patients. Turkey is the most active international country with 11 centers who enrolled about 30 patients. Personally, I think that all the different nations are very different. So I think that some conclusion can be much easily drawn within each country rather than, across different realities. So our first effort will be dedicated to try to have some conclusion from the Italian population. As you can see, most of the patients were enrolled from the northern of Italy. You see that these are Milano, Bergamo, and Brescia, the three most hit cities, and other centers in Milan. Also Genova, my city, from the north of Italy, and then Piemonte. But also we have some cases also from the south of Italy. You see 14 cases from Naples. And there's a very long tail here. I just reported the centers reporting more than 4 cases, but there are many, many centers with just 1 case. You see in Italy, 86 centers were joined this initiative. I must tell you that this was a very nice country collaboration. So a lot of very small centers joined the initiative, also centers that are not involved with the Italian Neurological Society, but since they knew about this initiative and they had some cases, they joined the initiative and registered, maybe with just one case, but everything is informative anyway. Here's the list of international centers. You have centers from all over the world, but just as I told you, just Turkey started enrolling patients. So these are the results of the publication. You know, this publication was a sort of nightmare because, you know, we chose the format of a letter, and we sent this letter at the end of March, but it took more than 1 month to be published. So, you know, I think that we must think to another form of communication for the next batch of results, because, you know, we sent the letter and the editor told us that in a few days the letter would be available, but really, we don't know why, but it took more than 1 month. Anyway, the results reported in these letters are not so, informative because the cases are still low. I can tell you that what we observed in this sample is replicated in the larger sample. So we have about 25% of patients with a positive test. So in our sample is about 150 now. And you know, this is the most informative portion of the sample because all the reference, all the national reference we have about lethality, mortality, and I mean, all the statistics are reported based on confirmed cases, not on suspected cases. So, for example, in this letter, we reported about 5 deaths. Fortunately, up to now, the deaths remained low. I mean, we had just 1 additional death. So overall, we had 6 deaths in this sample. But to understand whether this number is low or high, we must compare with the lethality of the general population that must be clearly, carefully adjusted for age and sex. Because, you know, MS is a disease of young people and mostly of women. So the mortality in this category is expected to be very low. Anyway, so I'm just giving you rough numbers because of everything I'm saying must be still accurately calculated and validated. Roughly speaking, we estimated that the number of deaths expected in such population, in such group of positive cases, would have been 5, and we observed 6. So, I mean, it's close to the expected lethality rate of the general population. So, as Heinz was saying before, there are no signals of dramatically increased mortality in this sample of patients. Of course, I mean, the numbers are still very low because, you know, a number of 5, 6 is, I mean, the proportion and the lethality rate can change if we observe 2 additional cases. So anyway, it's clear that there are not big, incredibly high signals of mortality. The other issue that we are assessing in our sample is an increased risk of infection among, according to different therapies. And of course, we are mainly interested in anti-CD20, not just an increased risk of infection, but also a more severe disease course. Probably I will go. So these are the 2 objectives that we are investigating now in our cohorts. And these are the challenges we must face. First of all, more aggressive drugs are monitored more intensively. So there's also the issue that even if we observe an increased frequency of patients in ocrelizumab among the infected, this can be due to the fact that if you are in ocrelizumab, you are tested at higher frequency than if you are in interferon, for example. So we must be very careful about this possible bias. And the second challenge is that the sample is not fully representative of the Italian MS population. So we have, our reference is the proportion of patients in each drug in Italy. And we must correct this proportion for the fact that most of the people come from the north of Italy. And maybe in this northern region, the use of ocrelizumab is higher than in the south. So, I mean, there are many issues that indicate that we must be very careful in drawing conclusion. Because the size of the sample is big enough to draw conclusion now. Our p-value is very stable, and but before giving recommendation, we must be very sure about what we are saying. About the outcome, the longer term outcomes, we are trying to define some composite outcomes because, of course, death, fortunately, I mean, we don't have enough deaths to conclude for a higher death rate according to therapies. So we are considering also the access to intensive care. Hospitalization is the easiest, but not just hospitalization, because hospitalization can be also a biased outcome because you tend to hospitalize patients who are in more aggressive drugs because you are worried about that. So we are also classifying the pneumonias and the severity of pneumonia as an outcome. Also, I mean, we must be very careful about reporting bias because clinicians who have patients in ocrelizumab tends to report this case maybe more often than patients who are in interferon or in other kind of drugs. So this is my report. I do hope to we will be able to report the numbers a little bit faster next time than with the first publication. We were suggested to put the data on medRxiv or this open access journal before the publication, so that I mean, once we have reached the consensus about the data presentation, in order to make data available in a faster way. And that's all.
Thank you very much. Yeah. Okay. I think we will move now to the last speaker, this is Cerlia Oreja. She is the head of the MMS unit at Hospital Clínico San Carlos in Madrid, and she is going to present us a short update on the Spanish MS COVID register. Celia, I see you are muted. I think Celia is muted.
Yes,
Hello,
you can hear me now?
Yeah.
Now
Yes,
it's okay, perfect.
Perfect.
Okay, perfect. But now I cannot put my slides. I try to put my slides, but I don't know if you can see. Can you see my slides? I don't know if Maria Pia was close to the others.
Yes, we can see your slides.
Yes?
Yes.
Okay. Okay. So that here's the register of the Spanish Society of Neurology. So that some of the data are under embark, so that I can know so many things. But now, until now, we have 170 patients infected with COVID-19. I think that is a small part from all the patients that we have in total in Spain. But when we put all together that I know, there should be now around 300. As you see, the average age is 43, and we have a range from 70 to 77. And one important thing is many of them, so 44%, they were with comorbidities from all these COVID-19 patients infected. When we look at the different kinds of patients, you see that the most of them, they were relapsing remitting MS, 82%, secondary progressive MS that was less, and only 6% of the primary progressive MS. And when you look at the EDSS, you can see that was a 1.93 for the relapsing remitting MS, and more, so around 6 for the patients with the progressive disease. So when we look at the treatments, it's very similar to the Italian. So we have all kind of treatments. As you see, we cannot see signals from the CD20, anti-CD20. So we have in our hospital 2 of them with ocrelizumab, and both of them they were hospitalized. But in really from all this cohort, from the Spanish cohort, we have from all the treatments, and they were hospitalized 28 of them, 28 of these 170 patients. Only one patient was in the intensive care unit, and he died. And from all the patients, a little similar like in Italy, not all the patients, they receive a PCR. Only normally the patients with a moderate to severe symptoms, the patients that they have mild symptoms, they don't receive a PCR, at least in the beginning. Now we can do more PCR than at the beginning, so that we have 44% of the cases, they were positive with the PCR, and 6% they were now positive with the serology, because now we are doing more antibodies test than PCR. And from the 2 patients, they have 2 patients, they die. One was a female with a relapsing remitting MS, and the other was a male with the secondary progressive MS. I think our results until now and the results of our hospital, they I think are similar to the results of north of Italy, more similar than in the other countries. And that was all from the Spanish register. I cannot say more because some of the data are in the embark. Thank you.
Thank you very much for the update, Cerlia. And I think we can make up a bit for the late start. So maybe we can go quickly through some of the questions. So most of them are directed to Heinz. The first one is more like an observation concerning the pseudo-Delphi study, mentioning that it has very few contributors. So I don't know if you want to comment on that, Heinz.
Yeah, I mean, it's definitely not a super scientific and formal process. So we just did a proper search, and we ended up in maximum 20 different statements. So that is the highest rate of, let's say, the denominator. And some of the statements, they didn't include certain aspects. So the denominator and the overall number varies, as I said, and the maximum is something like 20.
Okay, thank you. Then there's a comment on the effect on IL-6, as maybe looking at it from the other side, as in maybe it's not very good, as most of the severity on COVID is related to elevated IL-6 levels, sorry.
I honestly have to say, I don't know how to interpret this, let's say, correlation and conclusion. I don't know what the key drivers of IL-6 in the presence and absence is. So, I mean, I'm really not an IL-6 specialist. I would say I would have interpreted it very conservatively in a way that obviously at least B cells don't produce so much of IL-6, and in case they are absent, they wouldn't produce even more IL-6. So it could be interpreted that's not necessarily a bad thing not to have B cells in such a condition.
Well, I guess we will have to research a little bit.
It's pretty complicated thought, I would say.
Okay. So there's another question concerning the Roche data. Does that include age and sex of patients?
Yes, it does, but I don't yet have the original full manuscript. I just got these numbers for this, but it includes age and sex. Exactly.
Okay. Then there's another question also saying, should the screening of SARS-CoV-2 antibodies be included in the screening before anti-CD20 therapy if there is the risk for some reactivation, for example?
Well, I think that's an extremely interesting and relevant question. So the key problem is that we don't really have, I think, or I believe, a reliable test for SARS-CoV antibodies and what they really mean. Once we would have that, that's definitely something that helps us. So I was most intrigued by thinking while preparing this talk about the problem that some of the patients might have in mounting really protective immune responses, and whether they would have mounted protective immune responses even, let's say, being on B-cell depletion and undergoing a COVID infection, would they then be protected? But we are even less far with our knowledge that in the general population, what does a SARS-CoV antibody really mean? And I think we need more knowledge. Once this is a standardized assay, I clearly would give it a yes, but we have to correlate it to, let's say, the general meaning in the population, to relate it to what does it mean in a B-cell depleting condition.
Okay, then next comment is more towards Maria Pia's numbers, saying that untreated MS patients have 3 to 4 excess all-cause mortality compared to healthy controls. So it's mentioning that your numbers are encouraging, Maria Pia?
Yeah, I confirm that among the 6 deaths, 4 were untreated. So, I mean, and the other 2 were, one in dimethyl fumarate and the other in rituximab, but both of them were with high EDSS. The rituximab patient had an EDSS of 7, and the dimethyl fumarate was 6.5 with comorbidities. So, I mean, the evidence we have up to now is not related to MS drugs. The mortality seems to be in patients, mostly in patients who are untreated. That's reassuring, I think.
Yeah. Then the next question, I think, could be for anybody. Basically, mostly people just having data on registers. Is there any data on neurological described COVID complications in NMS COVID infected patients?
Not yet, at least. You know, we have some delay in collecting the information because this is a sort of retrospective study, because, you know, neurologists collect data about patients with MS who are infected, because sometimes they, if for example, the infected patients are in intensive care unit, they don't have access to the patients. So they collect data retrospectively about what happened to MS patients. And up to now, we didn't have any reported neurological complication related to COVID. Maybe in the future we will be able to collect something, but up to now we didn't have anything.
Nor have you had any MS worsening per se, for example?
Not, at least it was not reported.
Can I bring a comment?
Yes, please.
This is Pia Sormani from Montreal. In my place, any patient over 60 coming in with a stroke is considered as COVID positive unless proven otherwise. I don't know if you do the same in other centers, but that's what we do here.
Yeah, well, in Spain, as far as I know, most, if not all centers are doing it that way at this point. Well, at least when we had the highest peak of contagions, yeah.
Good, thank you.
I can speak for Germany. We are not doing it like this. Let's say stroke as a complication of COVID-19 is extremely rare condition. But what we are now doing is we're screening any stroke patient, irrespective of age, with a CT scan of the chest and using the CORAD score to triage them either onto the infection unit or into the stroke unit. But we're not considering, let's say, stroke as a specific condition that is so frequent that we would, first of all, consider it in age above 60, a COVID stroke. So I wonder how many you really have then in the end.
Yeah, in our case, I don't know the numbers. I only know that we also had to act that way specifically because we were converted into a COVID hospital. So basically, anybody who entered there was suspected of having it. I guess that was one of the things that can vary, and also how high the peak you have in your countries or communities are. That is what will probably lead what you do. I know the people at vascular neurology are collecting all this data, but I don't know the numbers right now. Okay, so I think that will be enough for tonight. Next, I think we will have other speakers for next week who had to leave before, like Bruce Bibo from the NMSS, and also Nick Noy from the MSIF. So they will join us for the next call to present their data. Thank you very much for joining us, for bearing up with us, and I hope you enjoyed the talks. See you next week. Bye.
Thank you. Hello to all.
Thank you for the speakers as well for joining us again.
Bye.
Be careful,
Thank you.
everybody.
Bye.
Thank you. Thank you very much.